Can everyone see my screen and hear me?
Yes.
Perfect. Okay. Well, good afternoon, everyone. Thanks for the opportunity to present. I wanted to share with you some of the work we're doing around stomach cancer, and specifically a study that we're just starting called a prospective cohort of individuals at high risk of stomach cancer. We can advance a slide here. So my goal is to give you just a very broad, brief introduction to stomach cancer, also called gastric cancer, talk about the risk factors and epidemiology, both in the United States as well as specifically in the Alaska Native population, and why there are some of those differences, and then tell you more about our study that we're just starting this year. So just a very broad gastrointestinal anatomy. When you eat, food goes from your mouth down your esophagus or swallowing tube into your stomach. It then goes on to pass through the small intestine onto the large intestine, also called the colon, and then out into the toilet. And so that's the normal pathway of food. And so our area of interest today is the stomach. And the stomach has many different parts, and I won't go into all that level of anatomical detail today, but there are many different types of cells in the stomach. In general, the stomach's job is to squeeze and to break up food products, and then to help a more digested food bolus pass through the pylorus, the end of the stomach, on into the small intestine, which is where the absorption of nutrients occurs. So the stomach's main job is really just to help break up food. But sometimes things can go wrong, and you can get malignant cells or cancer cells forming in the lining of the stomach. And usually it starts in one spot, then involves the deeper down mucosal layers, and then into the muscular layers, and then sometimes beyond. And so that's when we consider this a stomach cancer or a gastric cancer. The symptoms are a bit vague, though. Patients often complain about abdominal pain, dysphagia, or trouble swallowing sometimes, unintentional weight loss, a feeling of bloating, nausea. In some cases, there's some bleeding with some vomiting of blood, also called hematemesis. But these are very general, sort of broad chief complaints, and there's a lot of things that can give you abdominal pain and weight loss and bloating, many things that are unrelated to cancer, and so it often makes for a very challenging diagnosis. Because of this, when we do discover stomach cancer, it's often very late stage. Sometimes there are no symptoms early on, and so by the time symptoms develop, a cancer is already present, and often in stage 3 or stage 4, meaning that it's already spread to deeper layers in the stomach and sometimes beyond the stomach to metastatic disease. And so what we're really talking about is gastric adenocarcinoma. This is the most common type of stomach cancer. There are some other types, much less common types. But gastric adenocarcinoma is the most common. And there are many risk factors. So the things that we think about are first-degree relatives. So if mom or dad, brother or sister had stomach cancer, your risk is at least somewhat increased, and that's probably related to genetics, but may also be related to environmental factors. We know the Helicobacter pylori, which is a very common bacteria found in the stomach, particularly in Alaska, is considered a carcinogen by the World Health Organization, and does have some increase in stomach cancer. It's a very challenging bug to treat, and so common that it's very hard to get rid of with a very difficult antibiotic regimen, a lot of resistance to the antibiotics that we use, and often there's reinfection. We know there's some association with Epstein-Barr virus in some cases. We think there's a big dietary component. So particularly people that have a diet that's very low in fiber, meaning fruits and vegetables, but high in salted foods, smoked foods, particularly nitrates and nitrites. This is also why we see more stomach cancer in the Japanese and Korean populations, because they also have a diet that's very rich in these foods. We know there's a tobacco use component, obesity, which is linked to many cancers. And then, although very low risk, probably prior gastric surgery has some risk. And I can respond to any specific questions if you have about any of these things. But overall, gastric cancer is not very common in the United States, and I'll show you some of that data. But because of that, there's no recommended sort of standard routine gastric cancer screening recommended. So similar to what we have for, or different than what we have for colon cancer, where we do screening colonoscopies, you see a polyp, you take it out, you lower your risk of colon cancer. There's nothing like that for stomach cancer. There are some different tests that are available if you're concerned about stomach cancer and looking for that, including a swallow study, an upper endoscopy where we use a camera that we look down into the swallowing tube of the esophagus or the stomach. And there are some very, I say basic labs, although there's nothing that's conclusive for diagnosing stomach cancer. But there are some biomarkers that we sometimes try and use. Many of these are still in the research stages though. This is an example of an upper endoscopy, so opposite of a colonoscopy, but very similar camera, a little bit smaller, a little thinner, which goes down into the stomach and allows us to visualize the mucosa of the stomach. We also have a channel in the scope where we can take biopsies of the stomach, including a specific area, or if you see one spot that just looks a little more concerning, we have the ability to take a biopsy of that area that then can be sent to pathology and reviewed under the microscope to look for subtle changes that may be concerning for either stomach cancer or precancerous changes that increase your risk of developing stomach cancer. But because there's no screening, sort of recommendations or guidelines, this is usually done when a patient already has symptoms. So usually when patients are coming to see me in the gastroenterology clinic, it's because they already have abdominal pain or bleeding or something else going on. And so we will sometimes do an upper endoscopy for further evaluation. And there's not a recommended standardized approach in terms of where you biopsy or how many biopsies you take. And so it's a little bit at the discretion of the gastroenterologist, and depending on the circumstances and clinical presentation. Some of the Japanese and Korean researchers are working on developing more standardized approaches, but sort of an ongoing discussion in the GI literature. And then one other thing to mention here is that generally we think of a stomach cancer as having one clear, discrete lesion, kind of like colon cancer, where you have a big polyp that you know that's the focus. Sometimes stomach cancer is like that, but other times there's really no visual abnormality other than maybe some redness in the stomach. And there is a stomach cancer that's considered a diffuse type of stomach cancer, meaning the entire lining of the stomach is inflamed. And those are much harder to pick up to find an exact location where that stomach cancer may have started. So how common is this? Well, if you look at American Cancer Society data and you look in the total US population, it is not very common. So it's 16th in terms of estimated new cases for this year, 2021, much lower than what we think of for breast or prostate, lung cancer, colon cancer. And if you look at estimated deaths projected for this year in 2021, it's also very low, 16th. So for this reason, that's part of the reason that there really is no guidelines, because it's not really considered a top 10 or a top 5 cancer in the United States. And so it hasn't been a major focus in terms of NIH dollars and research. Similarly, if you look at incidence rates over a 5-year period, stomach cancer again is very low compared to other cancers, so 16th on the list. However, this is not the case in the Alaska Native population. So this is data that just got published with our 50-year report. I know several of the people involved in presenting some of this data are on the or within the conference, and you can see that for that same 5-year period, or a similar 5-year period, this is 2014, 2018, stomach cancer is significantly higher in the Alaska Native population. So it ranks 7th among the cancers that we see. And so that comes out to about 17.2 per 100,000 in the Alaska Native people. That compares to 5.7 per 100,000 in the US white population. So more than 3 times the incidence of stomach cancer that we see. One of the challenges is if you look over time, so this is looking from 1969 to 2018, you can see that the incidence has been relatively stable. We really haven't made much improvement in lowering the incidence of stomach cancer in the Alaska Native population. And mortality is not much better. So stomach cancer is the 5th most common cause of cancer death in Alaska Native people. It's about 11.8. You can see on that table there, 11.8 per 100,000. In the US white population, it's 2.6, so more than 5 times mortality. And on the bottom right there, you can see the trend over time. And again, we have not really made much impact. It's been pretty stable over the years. So taking all of this data into account, back in July 2019, we had this 2-day, very large meeting at ANTHC. and it was really a collaboration with CDC and ANTHC. And we brought leaders from around the world, really, including from Japan and Korea, where they deal with significant rates of stomach cancer. And we brought them to Anchorage, along with experts from CDC, people who study Helicobacter pylori as part of their sort of life careers, people who study stomach cancer, as well as a very large group of community members from throughout the state to really sit down and look at the data that exists, what are the knowledge gaps, what can we do to improve cancer diagnosis and survival. And this was all published last year, describing the findings of this meeting. But one of the big outcomes of this was that we really need to develop some type of screening program, because we know that there's more risk in our population, and we need to do something about it. And so that's really where this study came out of. And it was meant to be a long-term study where you follow individuals over time who are at risk of developing stomach cancer, and try and identify either better ways to identify that stomach cancer earlier, where there are more treatable options, where it's not already stage 3 or stage 4 metastatic disease, but also is there some biomarker, some test, something we can pick up earlier that we can identify high-risk individuals early on and prevent that progression to stomach cancer. And so we have this collaboration with CDC, and through funding through the CTRP, we received some pilot project funding this year to try and tackle some of these issues. And so I'm not sure if everyone, I know many of you are familiar with the CTRP, but it's funded through the NIH. It's in cooperation with Montana. And it's really meant to explore health disparities in Native communities, both in Alaska and Montana. And so I would definitely consider gastric cancer to be a health disparity in the Alaska Native people. And so the goals of our study was to create a cohort, to have a group of people who are Alaska Native and who either have stomach cancer or are at high risk for developing stomach cancer over time. And that we would collect epidemiologic evidence and biologic data for participants at the time of enrollment and over the course of the study. And the goal really is that information from this group will allow us to better understand the baseline status of these high-risk individuals, but also the progression of gastric pathology if stomach cancer were to develop. And so the hypothesis is that by identifying these high-risk individuals, enrolling them, biobanking of specimens, so this is biologic specimens, and that over time, as new tests become available, doing some assessment of biomarkers and risk factors, that we're able to distinguish people who are at high risk of developing stomach cancer from those at lower risk, with the very broad vision being that we want to identify those at increased risk of stomach cancer, with the ultimate goal of enhancing prevention and early diagnosis, which translates to better treatment options. And so the main purpose is to have a medical chart review, demographic information. We have several different questionnaires, including social and family history, dietary history, and then that coupled with analysis of biological samples and the creation of a biobank of specimens to further evaluate this. The other component to our study, which is really sort of a little bit of the community approach, is to understand what the feeling is about this in the community. So how do folks feel about the study? The idea of biobanking, is it considered culturally acceptable? Are there challenges and limitations that we need to address? And those are sort of another piece of what we're trying to assess as part of the study. And so there are different phases. Phase 1 is what I showed you, where we had this large group of people get together and community panel and an expert panel and sort of member engagement and discuss the challenges, and that's really where this study was developed from. We're currently in phase 2, where we're assessing the feasibility of developing this cohort, this sort of initial recruitment and enrollment, as well as the collection of the biobanking specimens. And then phase 3 is really that over time piece, over the next 10 years or so, how do we expand this to a very broad cohort, a larger group, which will better power the study to have more robust findings. And throughout all of these phases, the goal is to engage the community, to assess for acceptability, to provide education about stomach cancer to the community, both to medical professionals, but as well as to the community members, and then to have a qualitative component that's coupled with a quantitative component. And so in terms of eligibility,
I'm sorry, Dr. Vindigni, we need you to finish up.
Speed up, okay.
Thank you.
And so we're both groups of people, those diagnosed with stomach cancer, those who have a first-degree relative, so mom or dad had stomach cancer, and those who have a precursor to stomach cancer called intestinal metaplasia. And so over time, these folks who would be followed with biospecimen collection. And these are just some of the different pieces, which I mentioned some of this already, but that we would collect and assess for, including blood, saliva, stool, urine, and assessment of H. pylori. And every 3 years, patients would have intermittent sample collection and questionnaires. And so during the initial study visit, the participant would be enrolled, we'd have questionnaire specimen collection, and then follow up every 3 years. This would not affect any routine clinical care. So if a person's due for an endoscopy for some reason, then we would do that as part of clinical care independent of the study. And a patient or a person can choose to participate in as little or as much of the study as they want to. And so this is just an example of one of the brochures that we give out to potential participants to see if they're interested, including on the right side there, you can see we're asking if you're not interested, are you worried about it taking too much time, or you don't have trust in the study, you feel uncomfortable with providing family information, etc. And then these are just some of the sample questions, and there's really a long list of potential questions that we're interested in, but these are some of the sample questions about information that we're looking to assess over the course of the study. And so as far as where we are now, there was a long delay in getting funding, which we have received now, and we've finalized our data collection materials. We've ordered all of our materials needed for biobanking, and we've presented the study to many potential participants, at least 15, it's a little higher now, who are interested, and we are just starting our enrollment process. And so many people have been involved in the study, including the CDC and folks at ANTHC. And so I will stop there. Sorry for rushing along at the end, and happy to answer any questions.